Okay, we're going to be talking about the mandible and the TMJs. And this is review, of course. So we have the coronoid process with the ramus, the body, the mental protuberance with your symphysis down the middle, your mental foramen on either side, your gonion, or your angle of your mandible. You have the neck and the condyle that makes up the condylar process. You have the velar portion also of your mandible. Looking at a lateral, we have the coronoid process, the neck, the condylar process, the mandibular notch with the ramus, the angle, the gonion, the body, mental foramen, mental protuberance with the pubis symphysis with the symphysis and the velar process. All right, so looking at the TMJs, you have your temporal bone, you have your capsule right here with your articular disc, and when we do the open and close, we're looking to see if this disc dislocates. You have your temporomandibular fossa, and the EAM, your condylar head with your neck and your notches there. Okay, this is CT. So we have the mandibular fossa with the mandibular condyle, and CT also we have the mandibular fossa with the mandibular condyle. So essential projections of the mandible. So when we do these, we're looking at the rami and the body. So we have a PA axial, the axiolateral and axiolateral obliques that we're going to be looking at. So with the PA for the rami, you're going to have the patient prone or seated, upright facing the vertical bucky if they can. You want the patient's forehead and nose on the IR. Your OML is going to be perpendicular to the IR plane, and your MSP is perpendicular to the IR plane. Your CR is perpendicular to exit the acanthion, and you're going to be 8 by 10, but you're going to collimate down to the mandible. So you can see here you've got your OML lined up, and it's exiting the acanthion. And this is what we're looking at here. You can see the mastoid air cells, the condyle, the ramus really well, and the body. The body's not as good, so I'll show you another one for the body. All right, so this is a PA axial for the rami, and you're going to have the patient in the same position. You're going to rest the patient's, upright or seated, and you're going to rest the patient's forehead and nose on the vertical bucky. The OML is perpendicular, MSP is perpendicular. You're going to angle 20 to 25 degrees cephalad to exit the acanthion. There you can see here, you've got your OML, and the angle they have here is 20 degrees exiting the acanthion. And you can see the body really, or the ramus, I'm sorry, ramus and the body better, I think. So the ramus looks really good here. It's nicely displayed. Okay, so when we're looking for the body, so the PA mandible, you have them prone or seated, upright facing the vertical bucky if they can. You're going to have the nose and the chin so that the anterior surface of the mandibular symphysis, which is right down the middle, is parallel with the IR. So we are, let's see, the AML is perpendicular to the IR, and the OML is perpendicular along with the MSP. So the central ray is perpendicular to the level of the lips, and you're going to center, of course, the IR and the central ray. And you're going to collimate to the mandible. So this is the position here. You've got your acanthomeatal exiting the lips, and you can see that we can see the body really well. You see how we don't see the ramus really well, but we see the body fantastic. All right, so PA axial for the mandibular body. So patients in the same position, upright or seated in a chair if you can. MSP is center to midline, nose and chin with the mandibular symphysis parallel to IR, and we've got the AML perpendicular to the IR. So the CR enters midway between the temporomandibular joints, and we're going to angle 30 degrees cephalad to exit the lips. Okay, so here they have the patient prone, so we're going 30 degrees, and we are exiting the lips here with your AML. All right. This is what it looks like here, really nicely laid out of the mandible. So we have your mastoid air cells, your condyle, coronoid, ramus, body, and your symphysis here. So this is a really nice shot. So there's also, which is not Merrill's, we had to pull this out of Bontrager, so it's important that you know this view too. So the AP axial mandible, so sometimes the patient can't do the prone. So you're going to do OML or IOML perpendicular to the IR, and as you know, it's a 7-degree difference between the two. So your CR is going to be 35 degrees. Caudad, or for the OML, and if you're going to use the IOML, it's 42 degrees caudad. You're going to center to the glabella, and your OML is going to be, you can see here, this one is OML. So OML, we're going to go 35 degrees to the glabella, and this is what it looks like here. So it shows us well. All right, so axiolateral and axiolateral oblique mandible. So you have the patient position is going to be seated upright in anterior oblique position. So they're going to be kind of turned a little bit. Their shoulders are going to be off-centered, and so you can get the patient real close to the image receptor. So the part position, lateral with the IPL perpendicular to the IR. You're going to do the mouth closed with the teeth together. You're going to extend the neck to place the mandibular body parallel with the transverse axis of the IR. Adjust rotation of the head to place the area of interest parallel to the IR. So here, if we're looking at the ramus, so if we are concerned that there's a fracture in the ramus, we're going to put the head in a true lateral position. If we're concerned that there's a fracture in the body, we're going to rotate the head 30 degrees towards the IR. And if we're worried about the symphysis, we're going to rotate the head 45 degrees towards the IR. So here, head in true lateral for the ramus, 30 degrees position towards the IR for the body, and we're going to go 45 for the mentum, okay? And we're going to do a 10 to 15 degree rotation for just a general survey. If we don't know what's going on with the patient, we're actually just going to oblique them just 10 to 15 degrees so that we can see an overall view of the mandible. So your CR, you're going to angle your CR 25 degrees cephalad to pass directly through the mandible region of interest. So you are going to take a combination of the angles. If the patient can't do a 25 degree angle, or the shoulder's in the way for you to do a 25 degree angle on your tube, you can do a combination of the angles. So if the patient is able to tilt their head about 10 degrees, you can put a 15 degree angle on your tube. So you'll have to practice this, practice with people that are really small and people that are larger. So your hypostenic and your hypostenic patients, so that you can figure out the tube angles. So you've got to do a combination of the two typically. You're going to collimate to the area of interest. So you employ the head tilt and not to exceed 25 degrees. So if you can angle the CR 10 degrees and tilt the head 15 degrees, or you can do a 25 degree cephalad angle towards the IR. So looking back here, when we are turning the head, this is taking your MSP towards the board, so the IR. So this is just turning MSP towards the IR. When we're talking about doing this, doing a combination of the angles, we're angling cephalad 25 degrees. So we have two angles that go into the mandible. One is the MSP towards the image receptor. The other is the top of the head towards the image receptor, or employing a 25 degree tube angle or combination to equal 25 degrees. So here, this is a true lateral, so we're looking at the ramus here. As you can see, they're in true lateral, and we're doing a 25 degree angle, which is working for this person here. Normally, we're going to come down a little bit because we're doing the side closest to the IR. So we want to make sure that the shoulder is not in your image. So if you see any shadow on your shoulder, and shadow showing here, you're going to have to tilt the head towards the board and take some of your angle off so that you can get in there so that there's not a shoulder in your mandible. And you can see here, turning the head, we're going towards we're doing a body here, so we're going 30 degrees, I believe. Let's go back. Yep, 30 degrees. So here, towards the body. So if the mentum is 45 degrees. So here, and here's the mentum. So doing it supine, so this is a 20 degree, so and the patient's able to angle from you can see here they're down about 5 degrees, so it's totaling 25 degrees. So we're looking here to make sure that there's no shadow on your board. So you're just going to have to practice this, okay? So you have your coronoid process here, your ramus here. We've got the body right here. So this is the side that we're looking at, is the side down, this one. So your hyoid is right there in your image. So you're going to want to try to get that out of there. It gets kind of tricky. Sometimes you can't and you're just stuck with it in your image. So your angle of your mandible there. You need to make sure you don't clip that off. You need to see the angle. Okay, so here is a steeper. Let's see. It's really good. We can see the temporomandibular joint here. We've got the condyle, coronoid process up front. The ramus here looks foreshortened, so I'm not sure. Not sure here. It says it's for the ramus, which it is. It does look good for the ramus. It just seems like it's maybe too steep. It doesn't look like it's right on top of each other, so I'm not going to say that this is great positioning, but it does show the ramus from superimposition, so we can't argue with that. All right, we're also going to do an SMV for the mandible. So you're going to have them seated or supine, and as you know, if they're supine, you got to put something behind their back so their head drops down. You want to hyperextend the neck to place the IOML parallel with the IR. If you can't get it parallel with the IR by placing the vertex or the top of the head on the image receptor, then you can go ahead and employ an angle so that you are perpendicular to the IOML. Your MSP is perpendicular, your CR is perpendicular to the IOML, entering MSP midway between the angles of the mandible. So with this view, you do not have to get all of the posterior skull. You just want to cover the condyles. So as you can see here, they have the IOML and they're angling to the IOML here, so they're coming in perpendicular to the IOML. Really important that this is all superimposed, which it is, the symphysis with the GAL, and you have your body of your mandible, and here's your ramus right here, and you have your condyle. So great image. Here's your petrous ridges, and you just have to make sure that you can see. I usually go back to the petrous ridges. You don't have to go this far back, but you want to be able to see all of the mandible and the condyle right there. So these are great. Okay, going into your TMJs. A lot of angles with these two. So your basic position is your apiaxial, which is the modified Townes, and axiolateral, 15-degree oblique, which is called the modified Law, and then you have the axiolateral, which is called the Schuler method, and then you have Panoramic, which is tomography, basically. So apiaxial TMJs, so the modified Townes. The patient is seated and upright if you can. The posterior skull is in contact with the upright buccal. So your MSP of the head is perpendicular and your OML is perpendicular. So you're going to angle 35 degrees caudad, centered midway between the TMJs, entering 3 inches above the nasion. So a lot of people say the hairline, but a lot of people have receding hairlines, so you have to be careful with that. So 3 inches above the nasion. And you're going to collimate to the mandible. You're going to do, on all these views, 1 exposure with the mouth open and 1 exposure with the mouth closed, if the patient is able to do it or if it's not contraindicated. So you can see here, got OML 3 inches above the nasion at a 30-degree angle. 35-degree angle, sorry about that. So OML here, and you've got 35 degrees coming down, 3 inches above the nasion. And supine, this is what it looks like. And here is your condyle, your ramus. They did a good job collimating. You could come down a little bit more, clean this up a little bit. So yeah, looks good. And a lot of scatter. Other than that, they've positioned well. So here is your condyle with your ramus coming down. So we're just looking The difference, here's your closed, it's seated in where it's supposed to go, it's right here, and then here you can see it popped out. So you can see that there's no fracture on either side, but hopefully you don't have scatter and quantum model at the same time. This image, I don't know, I'm not sure. Maybe too high KVP, I'm not sure. Okay, so here's your AP axial. So this is your modified towns. Still reviewing, this is just a different shot so you can see. So you got your OML perpendicular, your 35 degrees caudad, and it's here it's saying 2 inches anterior to the EAM. I prefer you guys just know 3 inches superior to the nasion. Talk to Jeremy, see which one he wants you to know either. Okay, so this is what it looks like here, nicely displayed there. All right, Schuler, so this is your axiolateral TMJ. You've got true lateral, you're going to do open and closed. You have your CR angles 25 to 30 degrees caudad, entering 1.5 or half an inch anterior and 2 inches superior to the upside EAM. So you're going to come forward half an inch from the EAM and you're going to go superior 2 inches to the EAM. And you're going to do open and closed. So you can see here they're using a 30 degree. So you can go 25 to 30 and they're using a 30 degree here, open and closed. So ½ inch anterior and we have 2 inches superior. So ½ inch and 2 inches. So ½ inch anterior and 2 inches up. And it'll give you where you need to be on the downside. So we're shooting for the downside TMJs. You're going to do open and closed. So here you can see 30 degrees, 30 degrees. So we're looking right at the downside here. Okay, so this is what it looks like. This is closed and you can see it sitting in its fossa. So very nice. And then you can see it open where it's popped out. So that's perfect. Perfect. Now, if anything, I would tell them that they need to collimate in nice and tight. It shouldn't be open this much, which is really scary to do. All right, and you can see here, and the, let's see, small dots. What's the big arrow? Oh, on the side away from is also seen. So here you can see this is the side furthest away. This is the one closest. And you can see it open here. So here's your fossa and it's way up here. All right, so axiolateral oblique TMJs. So one exposure, open and closed, ½ inch. We're going to do center, a point ½ inch anterior to the EAM. Rest the cheek against the image receptor. Rotate the MSP 15 degrees toward the IR. Your IPL is perpendicular and your canthiomeatal is parallel. So you're an angle 15 degrees caudad, exiting through the TMJ closer to the IR. It's entering approximately 1.5 inch superior to the upside EAM. So we're going to do a 15 degree angle, and you're going to angle 15 degrees with the MSP towards the image receptor. So here we're going to do 15 degree angle with 15 degree MSP towards the board. So here's another picture. You can see we've got your rotate skull 15 degrees towards IR, and then you're going to angle 15 degrees caudad, and then you're going to take your CR and it's going to go 1.5 inches superior to the upside EAM. So this is called the law method, and the way that I remember the law method is 15, 15, 1, 5. So 15 degree rotation of the skull towards the image receptor, 15 degree angle, and a 1.5 superior to the upside EAM. So 15, 15, 1, 5 is the law. So hopefully that'll help you remember. This is what the law looks like here. You can see your mandibular fossa. If I can find my cursor, here's your mandibular fossa, and you have your EAM and your condyle here. So it takes the condyles and throws them off each other so that you can see each one. So here you got your fossa and you got your condyle. And here you can see it well. This is a better image. All right. Panorex. So this is a new digital unit. This is pretty cool. There's a lot of different units. Some of them still have film. Oh my gosh. Hopefully it's all digital. And you can see here in Panorex, the patient comes in nice and close. You want the IOML straight, so we call it parallel with the floor. And you have the chin resting on the little tray that they have. And this is what it looks like. So much easier than shooting a mandible, I can tell you that. So you can see your condyle and the full mandible splayed out perfectly. Pretty, pretty, pretty. All right, so evaluation. So evidence of proper collimation. So you want to see the entire mandible on your rami, your PA, no rotation or tilt. And the way we know if there's rotation or tilt, we're looking for the mandibular body and the rami to be symmetric on both sides. The MSP of the head is aligned with the long axis of the collimated field, and your brightness and contrast sufficient to see the bony trabecula, which I don't think they really have here, but we do have a problem. So you can see there's a large fracture through the ramus. This patient, they're aware of it. This patient's wired shut, so they can't move their mandible at all. And the PA axial for the rami, no, evidence of collimation. You want to see the entire mandible, no rotation or tilt, and the mandibular body and rami are symmetric on either side. You want your MSP of the head aligned with the long axis of the collimated field. You want to see your condylar processes, don't clip those off, and brightness and contrast, of course. So there you go. It's pretty. All right, axiolateral and axiolateral oblique. So you want to see collimation for the ramus and the body, so no overlap of the ramus by the opposite side of the mandible. So you want it free from superimposition. You don't want any elongation or foreshortening of the ramus or the body, and no superimposition of the ramus by the C-spine. So you need to make sure that the chin is out, so it's out away from the C-spine. So for the symphysis, you want no overlap of the mentum region by the opposite mandible or the shoulder. No foreshortening of the mentum region. So here you can see your axiolateral oblique. Looks good. There's no overlap. Over here, we do have the hyoid in there. Sometimes if you take the angle off, you can get the hyoid out of there and have the patient just tilt their head, lift their chin and tilt their head. Okay, so the AP axial TMJs, so evidence of proper collimation, no head rotation, minimal superimposition of the petrosa on the condyles in the closed mouth position, and the condyle and the TMJ below the pars petrosa in the open mouth. So you can see here, perfect, good job. And for your axiolateral obliques, evidence of proper collimation, you want to see the TMJs since you're imaging for the TMJs. The condyle lining in the mandibular fossa in the closed mouth, and the lining inferior to the articular tubercle in the open mouth. So usually we send these patients to MRI, and then we scan them in MRI. And we do open and closed mouth in addition. All right, so that is your mandible and your TMJ lecture. Really, really, really important that you practice these in lab. It's really hard just to lecture without showing you guys exactly what to do. So when you guys are in lab, please, please practice all the different angles for viewing the ramus, the body, the mentum. Practice your 25-degree combination of angles so that you can keep everything from being superimposition and get the shoulder out of the images. All right, good luck.